Fire away.
Okay, so we're going to continue where we left off before. We're going to start talking about Chiari malformations. So you're all familiar with three types. Chiari I are when the tonsils are greater than 5 millimeters below the foramen magnum, either with or without a syrinx. Some people like to stretch this to 7 or 10, but most people that I know use 5 millimeters as the cutoff. The Arnold-Chiari malformation, or Chiari type II malformation, is one, plus a whole host of other congenital changes within the super and infrapatellar space at the base of the skull, and typically also a lumbosacral myelocele. And then the Chiari III is a 2 plus occipital or high cervical encephalocele as well. And it's kind of progressive dysfunction, the worse the Chiari malformation is. So let's see, Sam, what do you think of this case?
So there's definitely more than just tonsillar ectopia. I think this is a Chiari malformation. Yeah, cerebellum's way down there. It's beaking kind of. So yeah, everyone, okay.
Okay, you already know the answer. Again, like beaking of the cerebellar tonsils, inferior displacement of cerebellar tonsils with associated syrinx. Yeah.
It's a little bit enlarged here. And here we can see the syrinx. Yeah. So the question is how to determine whether it's ectopia versus Chiari malformation. It's really kind of a matter of definition. If it looks like all the anatomy is pretty normal, you don't really have compression of the brainstem, and the tonsils extend 5 millimeters, maybe even up to 7 millimeters below the skull base, then I'll typically just, I usually won't use the term Chiari. But if it's more than that, and if you have these other kind of widening here, or if you see compression of the brainstem, and clearly if you have a syrinx, then I use the term Chiari malformation. And if it's greater than 7, I'll always use the Chiari malformation. And here we can see a syrinx. And there's a lot of debate as to the cause of syrinx. Most people feel it's due to some sort of obstruction here, probably some compression of the brainstem leading to increased pressure, which leads to the syrinx, but that's also somewhat controversial. Okay.
Okay. Again, sort of similar findings. It looks like the foramen magnum's a little tight, and there's a large syrinx.
Yeah. So clearly, I would use the term Chiari in this particular case. When you get this cervical spine, you can see that the syrinx really extends all the way up and down the cord. If you also got the thoracics, and there's the syrinx.
Okay, same thing. The tonsil is low, and what do you call beaking and.
So this is the cervical. Let me show you some other studies here. Here's this.
Yeah, some myelomenincocele there, down there. All this here.
It's enlarged and a little
right.
distal syrinx.
Chiari.
Here's some better images of the lumbar spine.
Right, we can see a big.
So you can see a big defect here.
Right.
And this is a Chiari II.
Mm-hmm.
Myelopathy. So our image all the way to the left is supposed to be, I guess, a coronal. There's some tilting. I think.
It's an AP.
Yeah, an AP, right? Some tilting and I guess some facet, either degenerative changes or I don't know if some fusion more superiorly. No, and lateral doesn't look like fusion. Is that a crown dens maybe on the open mouth view. I can't tell. There's some fusion of the spinal vertebral bodies more inferiorly. Yeah.
What's happening up there?
So the dens looks high compared to the axis.
Maybe a little separation here.
Separation.
Here's what the MR scan looks like.
Okay. Yeah, there's definitely separation here, and yeah.
Okay, so you can see that there's some deformity of the cervical spine here,
Yeah.
as well as the congenital fusion. This is a 27-year-old there. Here is C2, and we can see that there's a lot of space up here.
Yeah, separation
back there. So myelopathy of the cord. This is a patient who has Down syndrome.
Is that basilar invagination, or what do they call it?
I don't think you still have. Yeah, but I don't think it's really sticking up that far. I think what you have is instability at C1 too, and that's what's happening is that the dens is unstable, and it's no longer properly positioned with respect to the anterior arch of C1, and you're getting cord compression from this.
One thing I'll mention about Down syndrome, and that is that they have tissue that's very, very lax. On a scale of 1 to 10, they're like a 2. I guess. What's that condition? Skin laxity. Geez.
Ehlers-Danlos, Sam said.
Yeah, Ehlers-Danlos syndrome. So the Downs is very close to that, and they scar like crazy. So if you ever want to let a surgeon know when they operate on one of these cases, they better make sure they tell the parents that the scar is going to be pretty profound compared to other scars.
Thanks, John.
7-year-old female with multiple chronic complaints. So we have enlargement of the CSF space in the mid-thoracic spine posteriorly, some compression of the cord with increased sigma in the cord more inferior. Yeah. Okay, so just prominent CSF space.
So we can see these two things here. So there's something funny going on right in here. For the axial images, this is right through that area, and notice the cord is very anteriorly positioned here. If you go above it and below it, it's more normally positioned.
Look
if you go right at that level, this is what it is.
Like cord hernia.
Okay. So this is called a dural herniation. And now a number of papers concerning it, and it's thought to put action on the cord. It's probably some sort of scarring of the cord against the dura here anteriorly. To me, it seems like a very odd name for this condition. But it's just something to remember that sometimes you can get neurologic symptoms, and if the cord is really plastered against the anterior dura here in the mid-thoracic spine, that may be a syndrome that people can actually address. And it has a differential of a dorsal-thoracic erectoid web.
So they decompress that sometimes?
Sometimes. The ones that I've seen, they've ended up not operating on, but there are surgeries described for it.
Okay. 68-year-old female, pain radiating to right lower extremity for 2 years. So similarly, I think in the sort of upper thoracic area, there's prominence of the posterior dural space there. I wonder if there's a dural herniation. And it looks like the spinal cord sort of plastered to the anterior aspect of the cord, the canal.
And here you can see there's the deformity of the cord at this particular level.
New disc protrusion.
So disc protrusion that wasn't there before.
Thoracic cord herniation.
Okay, so 31 years, fall, quadriplegia, complete arm weakness, aggravation. So 2, 3, 4, 5. So posterior displacement of the C5 with compression of the cord, and the cord has been swollen with increased signal within it. And
so this is trauma, and just to remind us that trauma can be a cause of myelopathy of the cord.
So, what is this? I don't know if this was prior trauma or what. There's some loss of vertebral body height and at multiple levels. I think that's mainly syrinx in the cord, but and then some post-operative changes.
There's an anterior plate.
Yeah, some screws. Yeah.
3 levels.
Yeah, I mean, I guess the cord is. I don't know if I can say that the cord is injured, but there's a lot of syrinx there.
So another syrinx trauma. Another cause of syrinx besides what we talked about before is post-traumatic. And some people believe that you can actually have conditions which can be pre-cerebral myelopathy, and if you make the diagnosis early, that maybe there's something that occasionally can be done to decrease the risk.
Are there imaging findings that make that? What is that? Is that a clinical diagnosis for pre-cerebral or imaging?
So there are a lot of different theories as to what causes syrinx. So there's, technically, if you just have dilation of the central canal, it's hydromyelia. Syringomyelia actually means that you have fluid replacing neural tissue outside of the central canal. So it's more than just dilation of the central canal, and here we can see there's probably a lot of involvement of the cord outside of just the central canal here. Now the causes for this are varied and somewhat debated, but one cause that people talk about is that you can have any problem in the surrounding arachnoid tissue, which can affect the pressure within the vascularity which goes into the cord, which can then lead to whether or not you get basically necrosis of the cord. In some ways, it's kind of like AVN of the cord rather than AVN of the bone. Obviously, if you just have direct trauma, you can destroy neural tissue, and it can fill in just with fluid and be a syrinx. You can have increased pressure, which predominantly can either affect the vessels or it can just increase the pressure within the central canal and develop hydromyelia and so forth. So there are a lot of potential conditions that can lead to abnormalities within the cord that we call syringomyelia, because we see increased fluid pockets within the cord itself. And sometimes you can just see evidence of surrounding disease, which could lead to vascular problems, which going forward you can then follow the development of syrinx by MR scans. So there can be a number of conditions that can then affect the cord that can progress to syringomyelia. And you can pick some of these up early. And this just shows how the vessels, you can have changes in the CSF, you can have changes within the arachnoid space, changes within the vessels themselves, and then increased pressure within the central canal. So it's a complex process that can lead to the MR changes that we see. And this just shows typically the kind of appearance that you can see in syringomyelia, where you also have increased pressure within the central canal. And it's thought that a lot of these may be secondary to effects of the vascularity. So, and then you can develop cysts, which can rupture and coalesce to form larger cysts. And then obviously if you have blood products from trauma and so forth, you can develop necrotic tissue, autodigestion with lice, with enzymes which destroy some of the cord. So there are a lot of different pathophysiologic mechanisms where you can end up with defects within the cord.
Mostly trauma.
Yeah, mostly trauma. Okay.
44-year-old female, hemiplegia. Okay, we have a lung segment syrinx, which looks very heterogeneous.
So notice the signal here. We've got a lot of
looks like
difference in signal, and this is with contrast enhancement. There is some enhancement within it. And also remember that tumors can also
have the same,
produce syringomyelia. So you always have to be concerned about whether you have a neoplasm involved.
Okay, so we have T2, looks kind of dark on T2 and gradient echo.
So the patient he operated on, this is what it looks like after surgery.
Looks that we have syrinx still there.
So they operated on this patient because they were concerned that this might be associated with a tumor that was being obscured because of all of the signal changes. So they operated. This is what it looks like after surgery, and they found no tumor and just a lot of hematoma coagulation tissue within the cord.
Wow.
What are we seeing here? I don't understand this picture here on the right.
Here?
Oh, that's. No, I see now. That's like what hematoma post-op.
So here
that's
are these things in the cord. And this is literally a post-op seroma here posteriorly.
What operation do they do? I mean, they can't very well go to scoop out cord.
Better not.
Biopsies looking for
biopsies.
Oh, okay.
Wasn't it, the imaging looked like almost like it could have been blood, right? It was like T2 dark in a weird
Kind
way.
of blood, yeah.
Like you said,
Yeah.
right?
This is hemorrhage in the cord.
Could he have made this diagnosis on an issue?
Well, the problem is that some tumors can be not just focal lesions. So in a situation like this, I mean, the concern here would be that you had some sort of a vascular malformation which bled and it's being obscured due to the bleeding versus a tumor which is hemorrhagic. And it's hard to differentiate that accurately just on an MR examination. So another spontaneous hematomyelia. Typically thought to be due to AVMs. Often they're not well visualized, but you can also get it with hemophilia, hemangioblastoma, or arterial problems and so forth.
Okay, 80-year-old progressive weakness. So it looks like multiple levels with focal disc protrusions and some bone marrow signal, or spinal cord signal, the C7-ish level, yeah.
This is what it looks like on the axial image.
Oh, that looks like sort of the snake eye diastematomyelia picture.
Yeah.
Oh, the owl eyes.
Which are characteristic of the
ischemia
of the cord.
Yeah.
Here presumably is due to pressure from the discs.
So 24-year both leg weakness suddenly. So sagittal images and axial. Again, central linear increasing intensity within the spinal cord through the thoracic spine. On axial, it looks like central grammator is involved. So cord infarct versus ischemia look like probably cord infarct, 2 eyes.
So spinal cord. Okay.
What was the underlying pathology in that last patient? What caused that in that last patient? A young patient.
It was presumed. This one.
Yeah.
Yeah. It's presumed to be vascular. I don't know. I don't know this particular patient.
And it was only seen on. Sorry, it was only seen on axial.
No, the characteristic outside appearance is only seen on axial, which you can see this is all abnormal. So,
that's all ischemia?
yes.
Wow. Okay. That's crazy. Congenital scoliosis. Looks like scoliosis. Is that? This is a T1, so I don't know why it's so bright. I guess that's is artifactual, the posterior elements being so bright.
Right in through here.
Yeah, there's a lot of fat. I don't know what's going on. It's T1, right? Yeah.
If you look there, you have fusion of the posterior elements through there.
Okay.
Got a little bit of
Fusion there.
another fusion. Here's
Oh, okay.
another view of it.
This clip will fail, maybe this one. We saw a case like that recently.
So, this is
A lot of
kind
fusion.
a funny little thing here.
Oh, it's like a membrane.
So what is it? What are you thinking there?
I think clip will fail, but I don't know what this membrane thing is.
See this in clip files.
You have to look for a Klippel-Feil syndrome.
Yeah. And then here are the axial images.
Oh. So diastemetamyelia, right? Oh, what's the other one?
Yeah. This one, I don't think satisfied all the criteria for clinical file, but it's certainly in that same category.
I'm going to go with scoliosis, and there is pretty bad like S-type scoliosis of the thoracolumbar spine. Yeah, kind of like fusion.
So we've got a lot of congenital deformities here with confusion on one side,
widening on the other
flexors,
side. Pretty bad atrophy of the muscles. Okay. So we have enlargement of the middle finger on the right side. Yeah, maybe some syndrome.
Siamese twins. That's right.
So this is the Proteus Syndrome.
Okay.
People age very rapidly.
All of that was this?
What?
Every image you showed was the same patient?
Same patient.
So, but the organs were flipped, weren't they? Or were they just the images were flipped? One further back, one further side here. Looks like the stomach is on the right. I don't know where the heart is, but
yeah,
is that part of the?
Could very well be. I don't know which is left or right. Presume this is from Dr. Su in Korea, but it certainly looks like the stomach's on the wrong side.
Where are the scapulas, John?
Yeah, I'm not sure here, John. Let's see on the axe.
I just don't happen to see them.
I don't either.
It's there.
Here. Yeah, there it is over here.
Oh, okay. Finally, it came up. I guess it's my brain.
No, it's hard to just see it in images like this. So there are a lot of different abnormalities that are commonly associated with this syndrome.
So the stuff in the fingers were what, bone tumors?
Well, what are you referring to?
There was one with the hands, and then the fingers were like this bony growths. I guess it was before this. That one.
Don't you get an enlargement of organs? It's like
Yes.
Yeah.
Yeah, you get a lot of soft tissue bony anomalies with this, but it's rare. Typically seen if you're in a pediatric practice. Yeah, asymmetric growth. Yeah. So it can look a lot like neurofibromatosis with Fuji syndrome. Okay. See who's next?
You should.
58-year-old with neck pain and leg weakness. So it looks like there's fusion of the cervical and upper thoracic spine. It looks like it's one big block.
So here the epiphyses are all abnormal.
Okay.
So this is bundle epiphyseal dysplasia. You see that there's lack of fat in the marrow space.
Mm-hmm.
So this kind of stuff you see every day.
Would there be any motion there?
I don't think so.
Probably the neck. Yeah, that's what I mean. Atlantoaxial area.
Okay, so
C1-2 produces probably 50% of motion.
Yeah, the cord doesn't look great here either, so there may be a lot of motion here that's impacting.
Yeah, that's probably the problem. Probably be better off without any.
Yeah. Here's one image of it.
okay,
Here's the next image.
all right. So
Here's the next image.
it's a vascular structure there. Some anomalous.
What?
It's a vascular structure. Looks like.
What's happening here? Go back again. Here's the vertebral artery.
Right.
The next cut, there's the vertebral artery. It's coming into the frame.
So you're missing.
And it's going out of the frame and back down again.
We're missing. Yeah.
So, do you know what this is called? And what is significant?
Vertebral
This is
loop.
called the vertebral loop. Here are gradient echo images showing it coming up here. And you can get neurologic symptoms at this level due to this. Here's the loop of artery coming in there. Obviously, you want to inform the surgeon before they decide to operate on this, because it's called a vertebral loop. It can cause nerve root compression, and
I can assure you it wouldn't be me.
going in and operating.
Not in this area, I don't.
Yeah.
Or was there a thrombosis of the jugular in that last patient? If you go back to here, like every axial image you show on the left internal jugular looks like is loss of the flow void. Can you explain that?
Yeah. The issue is that you can have variable flow in the vessels, especially the veins, and so you're right. That could be the case. I don't think it was in this case, but if you have an acute venous obstruction, then it's going to be symptomatic. But the problem is that venous flow is very variable. And it's probably slow flow on this side and normal flow on the other side is most likely. But you need to look at all the other images to see. And the best image is really going to be the T1s to see if you have signal intensity, high signal intensity in T1. You can see if you have clot within the vein. Otherwise, the veins are typically low signal on T1. So you'd want to just check it with the T1.
Thank you. Yeah, that's true. That's true. Thank you. Okay. He's a 43-year-old female. There's some, I don't know, breast tissue asymmetry. I doubt that's what this is about.
I don't know why this is in the cervical.
There's some breast, yeah, there's some pectoralis. Is this Poland syndrome? Poland?
Okay, can you do? We have the answer.
Okay, so there we have schizencephaly of the brain. I guess showing what's happening here in the cervical spine.
Here we have triangular shape spinal cord. There's enlargement of the CSF space. Superiorly, there is compression of the cord.
This is, I think, post-contrast.
Oh, that's post-contrast.
Okay.
That looks.
So basically, it's what's going on here. What are these things? We can see here it's
it's
intermediate
T1. It's kind of like.
It's in T2, and then here we have a contrast that enhances.
The venous. Okay,
So these are huge epidurals due to chronic negative intracranial pressure. Okay, let's talk a little bit about MS. That's something you're kind of interested in. Basically, nowadays it's really the flare images that we typically use. I think there's some work also using diffusion images now. But here we can see the scattered areas of abnormal signal intensity within the cord. This is a patient with MS. Another patient is old. These are some of the very early MR scans of the cervical spine, where we still had a lot of phasing artifacts, and we can see multiple areas here also of increased signal intensity. And obviously, if you're concerned about this diagnosis, if you have multiple things like that, you can think about METs and other things, but these pretty much look different than METs. But generally, most people will recommend a brain MR scan, which tends to be more characteristic and obvious. Okay. And then why don't we go on into infections?
It's 68-year-old man, 1 week neck pain radiating to the left upper extremity. So it looks like there's bone marrow edema within the third and fourth vertebral bone, with corresponding stir hyperintense signal. It looks like there's erosion at the end plates, and the intravertebral disc is sort of eroded.
So what do you think this is?
Discitis osteomyelitis with infection spreading to the prevertebral soft tissues there.
When you see all this prevertebral soft tissue swelling, if it's trauma and you think it's hemorrhage, that's one thing. But if it's without trauma and fracture,
that's an abscess, isn't it, John?
It is. That's right. You really have to be concerned about infection. And here are the axial images. And again, you can see typically these start in the And the end plates, like we talked about before, they can rapidly extend into the disc, and then there's rapid spread within the disc to the opposite side. So it's very characteristic to see this on both sides, and typically involves two contiguous vertebral bodies because of that, even though it starts in one. And then we can see a little bit of pus extending below the posterior longitudinal ligament and then extending anteriorly, which is very characteristic of a bacterial infection.
Okay, so 37-year-old male with right shoulder pain, arm weakness, numbness, and fever. So cervical vertebral body. So there is evidence of destruction of the vertebral body. So with some, I think, inflammatory infectious phlegmon posteriorly.
Posterior back here.
Right. Yeah.
What about
There's also like a prevertebral soft tissue, right.
Abscess here.
Abscess there too.
Abscess up there.
Mm-hmm.
And deformity in the airway like
Right. So prevertebral.
You got this large prevertebral soft tissue swelling.
Mm-hmm. And destruction. Yeah.
73-year-old voiding difficulty, acupuncture 4 weeks ago. T1, 2. Okay, so there's a lot of what I guess is that. What is that? Contrast enhanced all the way to our right. Looks like contrast enhanced on the right. Yeah. So there's a rim enhancing.
T1.
Yeah.
T2 stir. And
yeah. So there's a rim enhancing fluid collection. I guess probably extra dural, which in this section would be compatible with an abscess.
Yeah, that's cheating. You don't know what section it is when you're reading up.
Yeah, that's true. I'd say correlate clinically for abscess. Is that gases from Paraplegia with muscle weakness and sensory paralysis below T6 demonstrate for 1 day. Dermatom for 1 day. Diabetes, chronic liver disease for 8 years. Chest pain after falling down 8 days ago. Okay, we see this kind of like maybe separated, heterogeneous lesions in the posterior epidural space at multi-levels, associated cord compression. Okay, now this is post. Post contrast. Here again we see that epidural thing. A hematoma.
Yeah, they drained out pus.
Oh, okay. Epidural.
Australian female.
Okay, so I see lots of, looks like T2 hyperintense, T1 hypointense, nodular, sort of foci all over the place.
Back pain.
Back pain. I think of some sort of bizarre infection.
What bizarre infection? The patient was not Jewish.
Was not Jewish. I mean, neurocysticercosis or cysticercosis comes. Oh, right. The pig thing, right? The patient was not Jewish. Got it. Yeah. In Australia? I thought it was sheep. Or is that New Zealand?
Yeah, sheep too.
Yeah, right. Pigs and sheep.
So neck pain and stiffness. 1 month later, patient found down after 3 days. Okay. Some anterior osteophytes. Maybe mild prevertebral swelling, maybe.
Okay.
Not.
That was not mentioned in this report. This sort of some degenerative disease here.
Right.
And when the patient came in, so this is when they first initially came in with neck stiffness. This is when they came back after being found down.
It's
After
got
3
worse.
days in their apartment.
It's got worse.
It's actually more reversal than normal lordosis.
Right.
Some lung thickening here. There's a CT scan.
Okay, so marked fluid inflammatory phlegmon there. Yeah, it's worse now. So prevertebral inflammatory, infectious.
And I think I got involved in this because this was a malpractice case.
Really.
Based on that first X-ray.
Yeah.
Actually, as we're coming here, this wasn't the only time it was missed.
Sorry, it doesn't make sense that this was left like that, just because you don't see the whole cervical spine on the side. Aren't they supposed to bring fish back and repeat it? The shoulder's covering like half the spine.
This was looked at and said degenerative disease, and the patient was sent home. There's some other images, but you really couldn't see much lower here. This is just called chronic degenerative disc disease. And then the patient was seen again, and then the patient was found down and brought in by the ambulance and had this study. And then here we can see the kind of pressing anteriorly, the edema within the vertebral bodies here. And then here we can see some of the pus. And this all turned out to be a staph infection. The patient actually did kind of well, surprisingly. They did train this, and then the patient was placed on antibiotics for an extended period of time and ended up walking out of the hospital.
Very good.
There's a time for a PIC line.
Yeah. Okay. Who's next?
42-year-old paraparesis, both legs, paresthesia, 3 months, non-specific past history. So the vertebral body and spine's process, I guess, are very sclerotic. There's a lot of soft tissue thickening. Yeah,
CT looks like.
It's very sclerotic again. Like an indolent atypical infection, I guess, could look like this maybe.
Like what?
TB maybe?
We usually have big cold abscesses, but
Well, there was some soft tissue around it, but okay.
there's a bone scan.
So a lot of uptake. There's a bone scan. Well, the first one is FDG,
Yeah.
right? Oh, and a bone scan. Okay, right. So
The first one, this actually,
It doesn't look too active, whatever it is, but the sclerosis, you'd expect that kind of uptake on the bone scan. But I guess the PET CT adds that it's not that metabolically active, so it's not probably an acute. So,
this turned out to be chronic osteomyelitis.
well, okay, yeah, all right.
You can see that
Was there
there's
surgery
central stenosis. I believe they did do surgery and they did a biopsy at home. And obviously they did an interbody fusion here.
Chronic like old.
Yeah, this is years old.
What organism was that, John? Did they say?
No, I don't know. And they might not have been able to get an organism out of it. But,
With all that tissue, corpectomy, there should be.
with chronic osteomyelitis, sometimes it's very hard.
That's quite an operation.
20-year-old female with headache and fever. You have single axial view. Okay, there's some increased uptake in the vertebral body, which is like T12.
Yeah. So well, it all depends upon how you model it. Basically, on 32307, this is kind of thought to be normal at this level. But the patient came back a little over 2 years later, and this is what they had at that same level.
So it's way too metabolically active, and it looks like there might be like a lucency anteriorly.
There's
Yeah.
lucency here. Maybe a little bit of soft tissue thickening.
Yeah, and
the PET scan was very active here. So the concern about this is this metastatic disease in someone with tumor, or is it infection? So they operated on it, and this turned out to be also chronic osteomyelitis, long-standing osteomyelitis.
59-year-old male, back pain for 6 months. So it looks like there's collapse of some of the upper thoracic vertebral bodies with destruction of the...
Again, it's that pattern of involving the inferior end plate and superior end plate of adjacent levels.
Yeah.
So whenever you see that, and it could be other thing. It could be trauma. It could be compression fractures. But when the opposite end plates are almost kind of normal, then you always have to think about, could this be an infection? So just remember that. And then, okay, here's what the stir looks like.
Okay, so it looks like the infection is sort of spreading anteriorly and posteriorly.
So you've got now the soft tissue thickening anteriorly, a little bit of disc protrusion at that level. Here's the T1. So now, there's a lot in the literature, if you read the older literature with MR, and I still think it's very helpful. When you see end plates on all the sequences like the stir and T1, and you can see kind of end plates there, like we're seeing here, and they go away on the T1, so you really don't see the end plates very well. That's very characteristic of infection. And it's not characteristic of fracture. And it typically, tumor doesn't spread, have this kind of an appearance with the discs. Tumor typically involves more the pedicle area or the vertebral bodies, and typically isn't centered on the disc. So this kind of a pattern is very suggestive of discitis, infectious discitis. Nice post-contrast. And there you can see axil's not normal either.
The posterior elements look like they're involved.
Let me go back here and see. Well, there certainly is involvement back in through here. You're right, John. They are involved.
That's bad news for surgery. Well, antibiotics, I don't know. You need somebody who does a lot of work in this area.
Yeah. So here's...
Which excludes me.
Okay. Here's a CT.
Same patient?
Yeah.
Okay, so it looks like there's sort of a lucency around a little sclerotic focus there too.
Almost looks like you might have
involucrum and a...
If this were osteomyelitis, what would this be?
That would
potentially
be like a Brody's abscess or a
sequestrum.
Sequestrum, right?
I'd be concerned about that. So they did a biopsy, and guess what? It's TB.
So TB is supposed to spare the disc space, right?
Well, TB typically will involve multiple levels of the vertebral bodies, and you'll typically have these cold abscesses between the two, and the discs are relatively spared. That's right. And it tends to spread external. Okay.
Okay, so 5-year-old Chinese female, negative lab, no pain or fever. So thoracic spine deformity, scoliosis. Oh, okay. So whole vertebral body has been destroyed. Yeah. Height loss, prevertebral stuff there. And yeah.
If I was to guess, are you going to guess?
I'm not going to guess. I know the answer.
I would go for tuberculosis.
Okay.
Okay. So infection definitely. So it could be TB. Yep.
So this is classic pocket disease.
These are quite common in that part of the world.
Yeah.
You don't see that much in America. I mean, it's pretty darn rare.
Right. Okay, so let's talk about other kinds of inflammatory lesions. Actually, why don't we stop here and we'll talk about non-infectious inflammatory lesions of the cervical spine next week. Okay, any questions?
Thank you.
Okay.
Have a good weekend, everyone.
Okay.